Well, good morning still. We have a couple of minutes left till the afternoon starts. Let me first say what a pleasure it is for me to be able to speak to you today, and I thank Roberta and the organization for asking me to share my stories about. Do you want me to switch over?
Yeah. That sounds bad.
All right. See if that works better. So as I was saying, I appreciate the opportunity to share my stories of health disparities. I can say that in 1967, when the school apparently was approved but not funded, that's not an unusual thing, I was actually a first-year medical student, having returned from 3 years as a school teacher in the middle of the Congo, where I was teaching chemistry and physics and mathematics. And it was that experience with extreme health disparity at the hospital next door to me in this school way up in the rural part of middle of Congo that actually got me to apply to medical school, which I did from the Congo, and I suspect I may be the only person who ever took their MCATs in the middle of the Congo. So I went out as a school teacher, planning to be a scientist and school teacher, and I came back pretty much a dedicated public health person. Although I went to medical school in 1967, just as this school was conceived, Tom Weller, my mentor at School of Public Health at Harvard, got me to the EIS, and many of the stories that I'm going to tell you today are stories that come out of experience as an epidemiologist with the CDC, where I spent 25 years. This is our campus in Brownsville, so I hope all of you will come visit. And our first story starts actually in Brazil, when I was still an EIS officer and a preventive medicine resident at CDC. And I went down as a representative to work with PAHO and the Brazilian government because they had a huge outbreak of meningococcal meningitis. This was the largest outbreak anybody had ever seen. There were over 150,000 cases throughout Brazil. In this 500-bed hospital that you see here in the middle, the Emilio Ribas Hospital in Sao Paulo, I stood at one day for 30 minutes and counted 13 ambulances that came just to that hospital with suspected cases of meningococcal disease. There were over 1,000, at the peak of it, there were only over 1,000 patients in that hospital with meningococcal disease, rooms full of people under peritoneal dialysis. So it was an incredible experience. And what was the driving force of this? Well, it was my first experience with the urban poor. I had not seen the level of urban poverty in my growing up in a small town in Indiana, or even in Africa, where I had worked primarily in the rural areas. But going to Sao Paulo and Rio de Janeiro, the crowded favelas were very impressive, and the disease swept through these like a wildfire in Southern California. It was really, really impressive. Well, what happened? Interestingly, this was just after meningococcal vaccine had been created by Mal Artenstein at the U.S. Army. So there was a vaccine, and in fact it had been given to Charles Mérieux at the Institut Mérieux at the time, which is now the Sanofi Pasteur. And Charles Mérieux turned his entire vaccine production facility into producing this vaccine. And he was able to produce 80 million doses of vaccine in less than a year. The Brazilian government, with PAHO, and I was very much involved in all this, vaccinated 80 million people. It's one of the largest vaccine programs ever. And it was, in fact, a model, and we brought some of our Brazilian colleagues to the U.S. after that because, if you recall, the original swine flu back in the 70s, this was going to be one of the models for how you might do massive vaccination. Now, the other thing that we were able to do at that time was to look at chemoprophylaxis. We actually did studies that developed the recommendations of rifampicin to contacts, which remains the standard of care throughout the world. The other thing we were able to do in our research, besides showing the efficacy of the vaccine, which we did, was to demonstrate the vaccine was safe for pregnant women. At that time, it was not thought to be, but as you can imagine, 80 million people get vaccinated, a lot of pregnant women, and we were able to study this and show that, in fact, there was no effect either on the women or, as was thought, perhaps producing immunounresponsiveness in children. This disease, however, unfortunately remains a disparate disease. There are thousands of children who die every year in North Africa from this disease, from both type A and C. And it's mainly not because we have far better vaccines than we had then, but it's because of cost. And the vaccine companies simply won't make the vaccine if people can't pay for it, no matter how much disease is there. This is changing somewhat by the Gates Foundation, and interestingly, about 2 weeks ago, a paper was published showing that pneumococcus and H. flu kill more children in Africa than TB, HIV, and malaria combined. We have highly successful vaccines for more than a decade for those. So this is a continuing issue with what we do. Even if we have the science, what do we do with it? Now I want to move on to another area, the hemorrhagic fevers, which I'm probably, I guess, a little better known as Palmer suggested. I had the opportunity to do all 3 of the first epidemic investigations for Ebola and work on Lassa for more than 15 years in Sierra Leone. These are diseases of the rural poor because of the ecology of these hemorrhagic fevers. It's the rural poor who encounter them. For most of these, the mortality rate can range from 25 to 90%, depending on the virus. And by the way, Bert, I decided not to put Ebola in the food. I thought that would really be bad public health. The outbreaks of most of these diseases are associated with hospitals and clinics, rural hospitals and clinics that you see here. The one in Sierra Leone is actually far more sophisticated than you usually see. And these are associated with hospitals and clinics because people come to the hospitals or clinics infected with one of these, and then they encounter poorly equipped hospitals, poorly equipped staff with poor training, and you end up with these terrible medical disparities where there's misuse of needles and syringes. The picture on your left, on your right there, the Ambuku picture, is what the outpatient clinic typically started with in a day. So those syringes would get used over and over as people came into the clinic. They might be pregnant women who were coming for prenatal care, and they would get their shot of vitamin B, which was thought to be a good thing to do, and so on and so forth. This has been the source of most of these epidemics, even though the diseases are clearly somewhat endemic. You have the hospital staff. They're often young people with almost no training and very poor education, and as you can see, totally inadequate equipment and support. In addition to that, of course, there are social disparities. Inadequate housing. And you can see the picture here. We have one of our traps. We were studying the distribution of mastomedes, which carries Lassa fever. But you can see the utensils here. Those utensils have food in them. And we were trapping rodents in the houses. So you can see that it's inadequate housing, obviously poor education and poverty. They're very related to these. We had some success with these diseases, nevertheless. Ribavirin treatment was developed in our program in Sierra Leone, and then later in Pakistan, where we were able to show that it was effective in treating Lassa fever. And Crimean Congo, the problem, of course, is the distribution of this drug. People can't afford to buy it, and it's poorly distributed. We were able to make the Lassa and Ebola prototype genetically engineered vaccines in our laboratory at CDC. Those vaccines have now been further refined by a number of groups. Unfortunately, none of them are even under production or even consideration because there's no funding. And of course, finally, we have new setbacks of people who are fighting over diamonds to be purchased by rich people. You've all hopefully seen Blood Diamond, but you can see the wars, and they have completely disrupted much of the work that has gone on in Sierra Leone. And I'll mention the work, the third story here has to do with the opportunity I had in 1983 to do the first investigation of HIV in Africa, which was in Kinshasa. And it followed a friend of mine who told me that they had been seeing some cases of this new disease in Belgium. I told you I'd already been a school teacher there. I spoke several languages, including French, and so it was an opportunity to organize a group to go and have a first look at this. What did we learn? We learned that the transmission in Africa was heterosexual, which was shocking to the administration at the time when we came back to show them the data. We conjectured from this that the epidemic was likely advanced and widespread simply because we saw a lot of advanced cases. The number of sex partners was key to the risk. And we found that already that perinatal transmission was clearly important for disease in children. What was the big health disparity? Well, there are many, but perhaps the single one, the most important one, is the poor women at high risk. This is a time of urbanization, massive people moving from the rural areas to the urban areas to find their little pots of gold. And when that doesn't go so well, women end up on the street, particularly, and this is a young woman who's just in her early 20s in Kinshasa. These women ended up on the street, and we saw a tremendous number of them who were already infected with HIV. Jonathan Mann, who I recruited to set up our first program in 1984 in Kinshasa on HIV, later founded the Institute of Health and Human Rights, really on the basis of his observation there and later of the health disparities, the gender health disparities with HIV. What came out of those initial studies? We established the first long-term, as I mentioned, in Kinshasa, long-term study of HIV. Kevin DeCock, who's currently the director of the WHO program for HIV, was an EIS officer with me, and we set up a program also in Abidjan and then later in Kenya, where he directed both of those. We had the first HIV conference in Bangui, Central African Republic in 1985. WHO supported that. We persuaded WHO to set up the meeting. And that was really the genesis of the creation of the idea of a global program on AIDS. Fakhri Assad, who was the WHO representative at the time from Geneva, and Jonathan Mann got together with a number of us, and that was the genesis of the global program on AIDS, which Jonathan Mann became the first director of. Finally, I came to Brownsville. And of course, I knew that we were coming to a community that was not wealthy, because that wasn't what I usually do. But I don't know whether I expected to find what I did. First of all, these are the two poorest counties, Cameron and Hidalgo, according to the Census Bureau, in the country. The population over 18, we found in our cohort study, is over 18, 52% is obese, 20% with diabetes. And we discovered that nearly 40% of our TB patients, because we have the highest TB rates in the country, have type 2 diabetes. This is an observation that's now been made from many countries, including China, India, and many other places. And so this is an observation that turns out to be very important for the control of TB. We also have renal dialysis, blindness, amputations. These are all common. And we have over 70% of our population has no health insurance. Now, this is a randomized study, so that's what we see. Less than 50% of our population is under any treatment for their diabetes. And we've estimated that the cost of diabetes and obesity may be relative to the income as much as 12% because of the high rates and low income compared to the rest of the country. So we have developed a whole range of responses to this in Brownsville that includes Tu Salud Si Cuenta, a program for a media program to intervene in diabetes and obesity. The coordinated approach to child health we introduced with the help of Steve Kelder and our colleagues here. So we have a range of interventions that we're trying to bring about in Brownsville to try to start to address these health disparities. We are funded by the National Center for Minority Health Disparities. Now let me just conclude with a couple of observations. I believe that no country has ever had as much potential to do so much good for so many people as this country. I believe that public health is a key player of that potential, but I believe that the public health should be judged not by the greatness of our science, which is important, nor the number of our patents or our papers, those being important nevertheless, but rather on the difference we make with them. And I'm certainly honored to work for a school of public health that uses science for the benefit of the community. And I hope we'll be able to say that over the next 40 years that we've done not just great science, but that the use of it in our communities will make an even greater difference to the poorest people among us. Thank you all very much.